So we'd like now to welcome Alecia Staines. Alecia.
Oh, right.
Okay. Thanks so much for coming, Alecia. We welcome you. We've got Kerry Heubel. We should have Bashi Kumar, who's absent because of the allergy that she's caught from her young children. Maree Kerr, who's from the Northern Territory, and Dr. Helen Pringle, who's here from University of New South Wales. If you could give us a bit about your background and how it was that you became concerned and interested in this particular issue. We see that you're a maternity consumer advocate and representative from the Maternity Consumer Network, but perhaps you talk about, as I say, your background, your qualifications, and how you became involved in this area.
Yeah, sure. It was back in 2011. I'd had 2 children at that stage, and I had really positive experiences, but it certainly was in contrast to what I was hearing from my peers, from my friends and colleagues who had high rates of intervention, a lot of trauma, no postnatal care or very limited postnatal care, and then I guess high rates of PND and issues with breastfeeding. I guess because I saw that it was in contrast to what I'd experienced, I really started asking questions about how this can happen, but also I guess if I could receive that type of care, why weren't all women receiving that type of care?
How has Australia's implementation of its obligations pursuant to CEDAW, that is the Convention on the Elimination of All Forms of Discrimination Against Women, improved since we first signed CEDAW in 1980 and then ratified it, I think it's 1984, and has anything improved, or what, if anything, has improved over the last 50 years? Because it's 50 years since we entered into CEDAW, and in your observation, has anything become worse?
Listen, I was born in the 80s, so I'm aware of how practices have changed, but it hasn't changed in a positive way. It's simply replaced, I guess, one lot of trauma or abusive practices with another. So we have gone from having enemas, routine episiotomies where women are being cut, often it was without consent back in the 80s as well, the routine separation of women and babies, and also, yeah, routine pubic hair shaving. So whilst that has tapered off, we've actually seen in the last few years quite an increase in the episiotomy space again. But things like caesareans, induction of labour have certainly skyrocketed. Like they've almost, actually, I think late 80s, it was about 18%, the caesarean rate. We're now at 37%, but that was 3 years ago. So I would anticipate, given the 1% rise we've seen in caesarean since the 90s, that we're probably up around 40% caesarean rate. We know from the World Health Organization that the caesarean rate should actually only be between 10 and 15%. I guess the flip side of that, or the outcomes that entail from having too much intervention, is that we're actually starting to cause more harm. But when we have surveyed women and looked at studies of women, the highest rates of trauma and mistreatment were in the cohorts of women that had this intervention, particularly around induction of labour. But frequently in the last few years, because of certain practices like the perennial tear bundle that have been implemented, I'm hearing more and more women saying that they didn't consent or they were cut without consent. I would go as far as saying it's sanctioned female genital mutilation that's occurring within our hospital settings.
Yeah, that's a really interesting and important way to look at it. Yeah. Perhaps I'll hand over to Kerry Heubel. Did you want to go to question 6, Kerry?
Yeah, sure. Still on that one.
Oh, I see. We'll say something.
Yeah. Well, the thing that concerns me, when you raise an issue of the husband tuck, you know, the ghastly sewing up of the episiotomy scar, just that little stitch too much.
Yes.
For the husband's benefit. I just find that so shocking.
Yeah, and it's certainly nothing that women are, like often the medical professionals would have women believe, like it's very gaslighty, that it's something made up. But I've heard quite a bit from women and the comments made around that as well. And then the subsequent repairs, which, you know, this is a couple years worth of treatment often. And even just for episiotomies that have kind of done well, women are saying that like the impact on their sexual function, it can be years. So none of that is ever thought about. It's never discussed with women because there is a very big push that cutting is better than tearing, which the evidence certainly doesn't support.
It's just so sexist to assume that that woman's body, that episiotomy, is for his benefit, not hers.
Yeah, exactly.
Now, can you tell me, how has Australia's implementation of its obligations pursuant to CEDAW improved since its last report back in 2018? And what may have improved for women over the last 5 years? Or, as you've mentioned before, become worse? I mean, clearly the rise in caesareans is one. Do you have anything else to offer on that one? That question.
I would say the improvements have come from women's side, actually realising that this isn't okay and it's not just part of birth to be mistreated, to be cut without consent, to have high rates of trauma. So I would say the awareness amongst women has certainly increased. The complaints that we help women with would certainly show that they're a lot more aware that this is a type of abuse. Apart from that, the other thing is the awareness around consistently, women have kind of been told almost to put up, shut up kind of stuff, because all that matters is a healthy baby or that they're alive. But I think increasingly women are realising that it's not a trade-off. You should have respect for maternity care, be alive, and your baby be healthy and alive as well. So that's certainly something that I think has improved, but that's been very much peer-led from women themselves, and through social media and Facebook groups and the support there, and definitely just general social media calling out this stuff. And since the creation of the Respect for Maternity Care Charter, I don't necessarily know whether a lot of women know about it, but it certainly raised awareness and encouraged more women to be speaking up about, you know, those rights of childbearing women, and having the World Health Organization and UN talking about it in the last, I think, you know, 2010 and then 2015, we've seen some talk about it, but it's certainly not from the government side of things or from care providers. I would say that side has plateaued or probably even gotten worse if we look at the data that's been captured around trauma and mistreatment. And because we know that the highest rates of trauma are often in the cohorts of women with high rates of intervention, we're going to assume, because we don't capture that data well on looking at mistreatment, mother's autonomy and respect in that space. So there was a survey in 2020, but prior to that we have no comparison data, but we know the cohorts of women with intervention had the highest rates of trauma, and because intervention's gone up, we're going to assume that trauma and mistreatment have gone up as well.
Yes. Yeah. Maree.
Also, number 6, you did mention talking about COVID restrictions and how that impacted birthing women.
Yeah, that was huge. Hugely traumatic for women. Lack of communication. We know in Western Sydney as well, there were, when they had really restrictive lockdowns, within a very small radius, there were hospitals doing different things as well around who could support women. Because we know there's a high migrant population in Western Sydney, a lot of their information hadn't been translated. So it was really, really difficult for these women to even understand. And for cultural reasons, they may have needed extra support and certainly weren't getting it. We were absolutely inundated trying to support the women, trying to lobby the government to change this. A lot of this stuff was done very, I guess, with like knee-jerk reaction, with no thought about human rights and certainly no thought about the evidence. So I would expect to see that cohort of women show more signs of postnatal depression and absolutely higher trauma rates from those areas.
Thank you.
Before Helen goes on, could I just stick on to 7, following Mary's lead, at paragraph 6C, you referred to working with a regional hospital in Queensland and engaging in more proactive training in staff and so on. Now, is that in medical hospitals? Because I'm training hospitals, because in our last discussion, we had a discussion, or we had evidence about body modification, and of course that involves the medical profession. So has your organisation had attempts or successes in engaging with the actual training of doctors in universities? Because that's where, I mean, it's good to be in the hospitals doing the training, and I know that if they're a training hospital, then that's where the doctors are being trained. But at the university level, are there any efforts being made there and successes?
Certainly. So what I'm finding is the midwives are a lot more proactive with this, and the doctors are a lot more resistant. And I think it's some of their training that doctors are right, and total disregard for the psychological well-being of women. Because that's where that rhetoric of all that matters is a live and healthy woman, which totally disregards her emotional and mental well-being. The hospital that we started in and have been back to twice is a training hospital. And the last training we did a few months ago, they actually wanted us in there as soon as like the registrars arrived. We haven't so much got into universities yet, but certainly midwifery cohorts and midwifery lecturers have reached out, and we have been into that space. So the Bachelor of Midwifery at universities. So that's still a work in progress, but never has it been done before. They have been really resistant, despite recognising that there is a huge need to change and to intervene. But again, it depends on the culture of the hospital. So some hospitals are really awesome. There's lots of midwives and lots of obstetricians who attend, but we can tell, because we speak to women too, we can usually tell by the attendance and how many doctors are there, and so the hospital culture, and then how it matches the mistreatment of women, because the ones that don't want to participate really don't care about the trauma that they're causing women.
Thank you. Yeah, Helen.
I noticed that you mentioned at one point that obstetric violence has been recognised as a form, or obstetric injury has been recognised as a form of gender-based violence.
Yeah.
Can you say a little bit more about where that is and what level that is, and does Australia do that?
Yeah, so obstetric violence is now a legal term, and I think CEDAW has actually helped with that. The UN has recognised it, and also the World Health Organization. It actually came, though, from South America, where there aren't a lot of midwives, so it did actually infer that it was obstetricians committing the violence. However, it now refers to the institutional-based violence, like maternity care setting violence against women. And it's a whole spectrum, from lack of informed consent to the things I described, like women being held down and being cut, like an episiotomy as well. So it's a very broad definition, and largely around that disrespect of the reproductive processes around birth.
So I just wondered, because there's been a few cases in the last few years, high-profile cases about doctors, doing rogue procedures and that sort of stuff. And I kind of, well, that's medical malpractice. but to say it's gender-based violence then puts it in a kind of different framework. And is that the framework that, is it more medical injury? I mean, I know that they can be both at the same time, but would Australia's approach be more like it's medical injury, or would it be like a gender-based violence with?
Well, I think it's gender-based violence because it certainly it happens because we're women. The laws are really loose, and there's very few pathways unless these women end up with a significant physical injury or their baby to ever get any kind of compensation, let alone any disciplinary action towards that care provider. It's hugely problematic. We deal with it a lot. AHPRA seems to be very weak on these things, and I think because there is not enough explicit guidelines around informed consent at that level, and then obviously up to assault. A lot of the replies and responses we will have back from whether it's an ombudsman or whether it's the regulating authority will be around saying that it was a woman's perception that she didn't get consent or that it was necessary. Yet the law is there around a woman having autonomy and making decisions for her and her baby. And that's very clear, like the fetus can never have rights that are more than the woman's, but it's not what's happening at all. So I think we need more law, but I think then too it's the lack of willingness to actually follow through with supporting that woman and her rights to bodily autonomy and making decisions for her and her baby.
Yeah.
Yes.
I just see at question 7, the question was, how is Australia's failure to meet its obligations pursuant to CEDAW impacting on the women you know or assist? And your response is, there are no laws protecting women against violence and disrespect against women in childbirth. Now, I suppose that, as was said, there'd be criminal negligence if it extends to that extent, or civil negligence action, but that probably would not cover something like disrespect for women along the lines of what Dr. Pringle was mentioning about, well, I don't know if it was about the medical faculty where there was an expose of the doctors tossing body parts about when they were learning, what do you call it?
Anatomy.
Yeah. Well, yes, and I see, what's the word for cutting up people's bodies?
Dissection.
Dissection, that's right, yes. And so now there'd certainly be, I think, you would be able to find a criminal law against people tossing body parts about, but we know that in medical training, whether it's still happening, in the past they've talked about some PowerPoint coming on in a medical training course, and then there'll be a pornographic image of a woman that shouldn't be there, but suddenly it comes up, and the person who's giving the training makes some sort of an excuse, and as if it's a joke. But I'm coming back to when you say there are no laws, how would you suggest that could be addressed in the law? The issues of violence against women in the, in the childbirthing area, and disrespect of women in that area.
Yeah, listen, I don't think we need to reinvent wheels. It's been done overseas quite well. And so it does look at not just like perhaps the physical injuries, but our biggest thing is the psychological injuries. The 1/3 trauma rate, and we know most of that is caused, due to mistreatment, lack of informed consent, disregarding body knowledge, so just doing things to women that I think if without their permission, and if it was outside the hospital in the car park, it would be rape, it would be assault, but it seems to be sanctioned because it's within the 4 walls of the hospital, or within the institution. So I think using that very the broad obstetric violence definition that's used globally, and then looking to what laws are working well for women overseas, I think is very worthwhile.
Yes.
Is some more of that covered in the 2019 report that you mentioned? So you mentioned the 2019 UN Special Rapporteur
Into the violence.
report. Would that would be, I think that would be useful for me to read at least. Yeah.
Yeah,
Yes.
it was interesting. It was only a 2-week time frame that was open for, so I don't know whether they had a lot of resources, but within that 2 weeks there were 40 NGOs writing in about the mistreatment of women, and that wasn't even then the individual submissions made as well. But it is certainly recommended there. I think how else do we get disciplinary action, I guess? And sometimes we need to have a deterrent, not just training care providers in how to be more respectful and what informed consent looks like and the fallout from that. But I think actually having deterrence and them knowing that I couldn't do this in the car park, so I shouldn't be able to do it in the birth suite.
Yeah.
Yes.
That looks good.
Have you had issues arising in relation specifically to the treatment of Indigenous Australian women? An Indigenous Australian woman who was on the Women's Advisory Council back in the end of the 1970s, Joyce Clay, referred to an era when Indigenous people had to be on the veranda of the hospital and couldn't be inside the hospital. Now, hopefully that's no longer the case, but have you observed, or your organisation come across race disparity also in this area?
Absolutely. So a few times I've spoken to remote Indigenous women, which I think that there are different cohorts too to perhaps the issues facing urban Indigenous women, but some of these women, their first language isn't English. So that in itself is huge because often there won't be translators. These women in remote communities were telling me they're often tricked off country. So flown out at 36 weeks, often with no clothes. They might have a toddler and things like that. So there's never time to organise care for other children. They also spoke of, because of the different tribes or groups, that then they're flown into a different community and forced to wait it out until they have their baby. But it's often very isolating. I found it hugely traumatic for me to even hear that these women are being tricked, forced into a plane. We absolutely need to be providing models of care that support these women culturally, but to maintain that connection with country, which from my conversations seems to be very important to them. So we have the resources, it's just a matter of governments doing it to provide services on country. And we know that it does improve outcomes. The studies from urban Indigenous models of care where we've got primary midwives, so building that relationship with the woman and wraparound services, the preterm birth rate has been reduced anywhere from 38% to 50%. So there absolutely are ways that we can be providing culturally appropriate care, but also better outcomes on the other side as well. I think the other thing is because there is a lot of mistrust in the system and not enough culturally appropriate care or continuity care or midwifery care as well, there is a reluctance to engage in the system as well.
Yeah, you've got recommendations here. I see that you've said, number 1, create laws to ensure obstetric violence is a criminal offence. Number 2, ensure all maternity care providers complete respectful maternity care training. And then every maternity hospital should be collecting data on women's experience to monitor the violence and disrespect using the Birth Labs Mistreatment Index based on the 7 rights of childbearing women. If we might come back to that, the Mother's Autonomy on Decision Making, MADM, and the Mothers on Respect Index. This was also recommended to the Women-Centred Care Strategy for Maternity Services, yet nothing has been done to capture this data. Perhaps if you could explain to us these 3 measurement indexes, the Birth Labs Mistreatment Index, the Mother's Autonomy on Decision Making, and the Mothers on Respect Index. Could you speak a little about those? Thank you.
Yeah, absolutely. So they are tools used to capture data from women's experience around, you know, were they autonomous in their decision making, or was there coercion, or the care provider centering themselves in that care. Obviously, the Respect Index is similar to that, but and it covers all the cultural, the low socio issues as well. So the picking up discrimination as well in these indexes or surveys, and they're often ranked as well, so you can get a score. The Mistreatment Index actually marries up with the Respectful Maternity Care Charter around those 7 rights of childbearing women. So it's very easy to see which places are traumatising women, basically, and not upholding their human rights or enacting the Respectful Maternity Care Charter. We use that, so I do know Bashi because she actually helps us run the Respectful Maternity Care training that we travel around hospitals and run. But what I've done with the Mother's Autonomy and Decision Making and Respect Index, I actually flipped it to start asking care providers questions. So they can then have a self-reflection tool to go, am I upholding the Respectful Maternity Care Charter? Does this woman have the autonomy? Am I upholding human rights? You know, am I am I overriding her rights or centering myself when I'm providing this care?
Just one question. Women who are experiencing this obstetric violence, how would you suggest they report it, or how would they deal with some acknowledgement from the authorities of what's occurred?
It's really difficult. We help them make complaints to usually the state-based ombudsman or regulating authority, to AHPRA, and then to the hospital. So often we'll try to go to the hospital board and CEO as well. But apart from one hospital, which is my local hospital, I've not seen anywhere in the country that's actually addressed these complaints well. It is really difficult. We have to prime women beforehand to say, listen, whilst I still think it's worthwhile making this complaint, your notes will often not reflect the experience, and be prepared that to be disregarded or be told that that was your perception of the events.
I actually, you're in Queensland? Or in yeah, because in New South Wales, I know that there was a Health Complaints Authority. I was on that authority probably it was 1990s. Is that the sort of regulatory body that you're thinking of in terms of what might be in your state and elsewhere? Yeah, so
New South Wales has a Health Complaints Commission, but it's very similar. Like, they're all very similar. Like I alluded to in the statement, that they often don't recognise a lack of informed consent in the maternity space, and it'll come under categories of like just miscommunication, which is it's not just miscommunication. It's you know, in some cases it ends up as battery. So there are huge issues. I've not come across one who does a particularly good job. There is Safer Care Victoria. They're not so much, well, they kind of do some of the regulatory stuff because they've had the cluster of baby deaths at Bacchus Marsh all those years ago. They seem a little bit more proactive, but these consumers, these women wouldn't know to go straight to Safer Care or who to contact. They often have to come through us, and we then help them with the complaint. So for women that don't know about our organisation, it really is, you know, trying to deal with hospitals, and often what happens is they just send it back to the hospitals to investigate themselves, and I've not seen a hospital that's done a good job of that at all.
So it has to really wait until there is a scandalous situation, as was in another area, but to gynecological, the doctor in Bega, and there have been ones in
South Coast.
England, South Coast, ones in England,
Darwin.
where, and it seems that there is, sadly, not some at least indication of misogynistic conduct, and that's why at the training level this issue has to be addressed and properly dealt with. But also on the issue of consent, you see, under United Kingdom law now, there's a Montgomery standard, which is more focused on what the woman was actually told and what information was provided to her, how much information was given about risk, etc., etc. And I'm not up with the consent here as to whether they've gone to that standard or retained the standard where you just simply look at what the doctor did and whether the rest of his or her profession thinks that the standard of care that was provided was an acceptable standard of care. Are you familiar with what the standard is now for consent to medical treatment?
Yeah, well, it's pretty much the latter. So I'm familiar with the Montgomery case, and what happened in Australia was then we had the obstetrician saying, well, women clearly need to start consenting for a vaginal birth. And you can't even consent for a physiological process. So they don't even understand the law, but it was totally lost when it got here. We do talk about it in the respectful maternity care training around what it meant was that the woman gets to make decisions. But we have a really powerful medical lobbying as well, and that was pretty much what came to Australia from the Montgomery case, was a lot of media around, well, now we have to create consent forms for vaginal birth. It was totally lost, unfortunately. But generally, what I see happening is the doctors usually supporting each other, unless it's completely, a cluster of bad things happening, but usually they will support each other around and I would have done that in that situation, and that's kind of closed case. And as you mentioned before, it usually takes quite a cluster before anything's done, which says to me that clearly our state-based, whether it's the health commissioner or the ombudsman or whoever it is in each state, isn't doing their job properly when these are first flagged. Because recently we had a case in central Queensland, and there was baby deaths, women forced into cesareans, cut without consent. Like, it was a big cluster. And then when they went back, there was a trail with the ombudsman that just wasn't being actioned. And so then you end up with, pretty severe outcomes in the loss of life before that doctor, I think, was eventually struck off. But hugely problematically was he couldn't get a reference. He'd come from Western Australia, couldn't get a reference, yet but in Queensland he was still employed, which I think is problematic as well, that, we're willing to take on these basically dodgy doctors as long as they relocate, and we seem to just forget the huge amount of trauma and whatever else, negligence that they've caused in other places.
Thank you.
Yes, there's another issue here of who said what. Did the doctor explain the process adequately for the patient, or is the patient just claiming that they didn't receive it? I'm aware of a complaint that went where the doctor the complainant maintained that she was not told of the alternatives available to her, and the doctor maintains he did, and the Health Complaints Commission held for the doctor.
Yeah, but usually what we find is it'll never be well documented in notes. So there is absolutely scope for women. On the back of the Montgomery case in the UK, they actually developed a decision-making aid, which we've tried to kind of personalise for Australian circumstances. But again, it's actually, I think it's training around that as well. I think doctors actually, in a way, think that they're 100% responsible for the woman, which isn't the case. They are service providers. They're meant to provide all the information, ask the woman what she wants to do, and then proceed. And if they're not comfortable, they should be getting someone else. But it doesn't happen like that. And I often hear, even you know, when I visit hospitals, doctors will say, well, I'm in charge and responsible, which I think is hugely problematic, that they don't understand that consent, how consent works, and that the woman actually has, that it's her body to make decisions about.
Good.
Thank you.
Yeah, thanks so much. We really appreciate your having come and your witness statement and the evidence that you've given today. And as we've said in the outline of witness statement, we'll be making a report of submission to the CEDAW Committee next year when they come to Australia to see how Australia's been doing on CEDAW. And you've made a number of points that we'll certainly incorporate into our submission. So many thanks for coming. Thank you.
Thank you.
Good.
Thank you.
Thank you. And we'll